Hey, future doctors. Thanks for tuning in to Spoonful of Sugar, a podcast made for medical students by medical students to help the medicine go down. My name is Larry Williams. I'm a student at the Penn State College of Medicine, and I'll be your host today. What if I told you that you could answer almost every board question on hyperparathyroidism without memorizing a single laboratory value? Today, that's exactly what we're going to do. We'll be talking about hyperparathyroidism, or in other words, an increase or inappropriately elevated secretion of parathyroid hormone, commonly abbreviated as PTH. So first, what exactly is parathyroid hormone? It's an endocrine hormone that is produced and secreted by the parathyroid glands, which are four small glands located in the neck just behind the thyroid gland. The primary role of PTH is to maintain calcium homeostasis, or in other words, to keep calcium levels within a healthy range. Why is calcium so important? Well, it plays an essential role throughout the body. It's critical for maintaining healthy bones, allowing muscles to contract, transmitting nerve signals, supporting blood clotting, and carrying out many important cellular functions. Another role of PTH is regulating phosphate. Like calcium, phosphate is an important mineral that we primarily obtain through our diet. Phosphate and calcium often work together, although PTH has opposite effects on each. In fact, some students jokingly refer to PTH as the phosphate trashing hormone, because one of its major functions is increasing phosphate excretion by the kidneys. While not an official name, it's actually a helpful way to remember one of PTH's key functions. So what exactly do I mean by calcium homeostasis and phosphate regulation? Let's take a broad look at the major effects of parathyroid hormone. PTH acts on three major organs: the kidneys, the bones, and indirectly, the intestines. Let's start with the kidneys. Within the kidneys, PTH increases calcium reabsorption, meaning less calcium is lost in the urine. At the same time, it decreases phosphate reabsorption, causing more phosphate to be excreted in the urine. PTH also stimulates the kidney to activate vitamin D. Specifically, it converts 25-hydroxyvitamin D, which is the inactive storage form, into 1,25-dihydroxyvitamin D, also known as calcitriol, the active form of vitamin D. This activated vitamin D then travels to the small intestine, where it increases the absorption of both calcium and phosphate from the diet. Notice that this is an indirect way in which PTH increases calcium absorption. Rather than acting directly on the intestine, PTH first activates vitamin D, which then carries out this function. Finally, PTH acts directly on bone. It increases bone resorption, which is the process of breaking down bone to release stored calcium into the bloodstream. As a quick reminder, bone remodeling is a balance between two major cell types. Osteoclasts break down bone, osteoblasts build new bone. PTH ultimately favors bone resorption, allowing calcium stored within the bone to enter the circulation. So I know that was a lot of information. Let's summarize everything we've discussed. Think of PTH as acting in three major locations. First, it acts on the bones to increase bone resorption, releasing calcium into the bloodstream. Second, it acts on the kidneys to increase calcium reabsorption, while simultaneously increasing phosphate excretion. Third, it stimulates activation of vitamin D, which then increases intestinal absorption of both calcium and phosphate. Overall, the net effect of PTH is to increase serum calcium levels while decreasing serum phosphate levels. Now you might be wondering, can PTH just continue increasing calcium forever? Fortunately, the answer is no. Our bodies have an elegant feedback system called the calcium sensing receptor, commonly abbreviated CASR. That's capital C, lowercase a, capital S, capital R. These specialized receptors are found primarily on the parathyroid glands, and to a lesser extent within the kidneys. Their job is to continuously monitor calcium levels in the blood. When calcium levels become too high, these receptors activate a negative feedback loop, signaling the parathyroid glands to reduce PTH secretion. This helps maintain calcium within a relatively narrow physiologic range. Since we've been talking about homeostasis, let's briefly review some normal laboratory values. Normal total serum calcium is approximately 8.4 to 10.2 milligrams per deciliter. Normal serum phosphate is roughly 3.0 to 4.5 milligrams per deciliter, and intact parathyroid hormone typically ranges from approximately 10 to 60 picograms per milliliter, although this may vary slightly depending on the laboratory. If these laboratory values seem overwhelming right now, don't worry. This is one of those topics that becomes much easier once you focus on recognizing patterns rather than memorizing every individual value. Throughout this discussion, our goal won't simply be to memorize laboratory numbers. Instead, we'll focus on understanding the physiology so that the lab values begin to make sense naturally. So before we move on to the different types of hyperparathyroidism, I'd like to give you a challenge. For the rest of this episode, try not to memorize the values. Instead, every time I introduce a new disease, pause for a moment and ask yourself 3 questions. What happens to calcium? What happens to phosphate? And what happens to PTH? If you can explain why each of these laboratory values changes based on the underlying physiology, you've truly learned the concept, not just memorized a chart. That's exactly the approach we'll use throughout this episode. Now that we have a solid understanding of what parathyroid hormone normally does, let's look at what happens when the system goes wrong. Specifically, we'll discuss the 3 major forms of hyperparathyroidism: primary, secondary, and tertiary. Throughout this episode, I'll periodically ask you questions. If you're listening while driving, walking, or studying, I'd encourage you to answer them out loud or think through them before I explain the answer. Don't worry if you don't know the answer immediately. That's exactly how we learned. So let's begin with primary hyperparathyroidism. Since we're talking about hyperparathyroidism, we'll already know that the PTH levels are elevated. Before we even discuss the causes, let's see if we can predict the physiology. If PTH is elevated, what do you think happens to calcium? Hopefully you said calcium increases. Now let's make it a little harder. What happens to phosphate? Remember that PTH causes phosphate wasting by the kidneys, so phosphate decreases. One more. What happens to vitamin D activation? PTH stimulates the kidneys to activate vitamin D, so active vitamin D also increases. Excellent. Without memorizing anything, we've already predicted the classic laboratory pattern for elevated PTH. That's high calcium, low phosphate, increased activation of vitamin D. That's exactly the kind of physiologic reasoning we'll use throughout this episode. Now let's define primary hyperparathyroidism. The word primary tells us that the problem originates in the parathyroid gland itself. Here's another question. If the gland itself is the problem, what kinds of conditions might cause it to produce too much PTH? The most common cause is a parathyroid adenoma. Other causes include parathyroid hyperplasia and hereditary syndromes such as MEN1 and less commonly MEN2A. All of these conditions allow the gland to produce PTH autonomously, regardless of the body's normal negative feedback mechanisms. Now let's put everything together. If I told you a patient has primary hyperparathyroidism, could you predict the laboratory findings? You should be thinking high PTH, high calcium, and low phosphate. That's a classic laboratory pattern you'll see repeatedly on board exams. Now here's a favorite board-style twist. Suppose I tell you that a patient has high calcium, but their PTH level isn't elevated. It falls within normal laboratory reference range. Would that rule out primary hyperparathyroidism? Actually, no. Remember our negative feedback systems. If calcium is already elevated, PTH should be suppressed. So a PTH that is merely normal in the setting of hypercalcemia is actually inappropriately normal. In other words, it's higher than it should be for that calcium level. This is a classic teaching point and an important concept to recognize for both exams and clinical practice. I know that was a lot of information, but don't worry. We're building this one step at a time. At the end of the episode, we'll tie everything together with a high-yield summary and classic board-style clinical scenarios. Now that we covered primary hyperparathyroidism, let's build on that foundation and move to our next condition, secondary hyperparathyroidism. Remember our challenge from earlier. Before I tell you the laboratory values, see if you can predict them based off the physiology. Don't memorize the answer, reason your way to it. Secondary hyperparathyroidism most commonly occurs as a consequence of chronic kidney disease, although we'll also discuss vitamin D deficiency in just a moment. So here's the question. If the kidneys are no longer responding appropriately to PTH, what do you think happens to calcium? Let's work through it together. Normally, PTH tells the kidneys to reabsorb calcium, excrete phosphate, and activate vitamin D. But if the kidneys are failing, they are no longer able to carry out those functions effectively. As a result, less calcium is reabsorbed, phosphate accumulates because it cannot be excreted efficiently, and the kidneys lose their ability to convert 25-hydroxyvitamin D into 1,25-dihydroxyvitamin D, or calcitriol, through the action of the 1-alpha-hydroxylase enzyme in the proximal convoluted tubule. Without adequate active vitamin D, the intestines absorb less calcium from the diet, causing serum calcium to fall. Now let's see if you can predict the laboratory findings for the patient with chronic kidney disease. What happens to calcium? It decreases. What happens to phosphate? It increases. And finally, what happens to PTH? It increases. Exactly. The low calcium stimulates the parathyroid glands to produce more PTH in an attempt to restore calcium homeostasis. That's why this condition is called secondary hyperparathyroidism. The parathyroid glands themselves are functioning normally. They're simply responding appropriately to another disease process, in this case, chronic kidney disease. Now here's another question. If PTH is elevated, but the kidneys aren't responding normally, does PTH still have effects elsewhere in the body? Yes, it does. PTH can still act on bone. As a result, prolonged elevations in PTH lead to increased bone resorption as the body attempts to maintain serum calcium levels. This explains why patients with chronic kidney disease often develop bone pain and other manifestations of renal osteodystrophy. However, chronic kidney disease isn't the only cause of secondary hyperparathyroidism. Another important cause is vitamin D deficiency. When most people think of vitamin D, they think of sunlight, and that's certainly important because ultraviolet light stimulates vitamin D production in the skin. Vitamin D is also obtained through the diet. Because it is a fat-soluble vitamin, it is absorbed in the small intestine, primarily in the jejunum and ileum. Once absorbed, vitamin D travels to the liver, where it is converted into 25-hydroxyvitamin D and is also called calcidiol, the major circulating and storage form of vitamin D. Remember, this form is still inactive. It must then travel to the kidneys, where the 1-alpha-hydroxylase enzyme converts it into the active form, 1,25-dihydroxyvitamin D, or calcitriol. Now here's another prediction question. If someone has vitamin D deficiency, what happens to calcium? Calcium decreases because less calcium is absorbed from the intestine. What happens to phosphate? Unlike chronic kidney disease, phosphate also tends to decrease. Why? Because vitamin D normally increases intestinal absorption of both calcium and phosphate. Without sufficient vitamin D, absorption of both minerals falls. Finally, what happens to PTH? PTH increases in response to falling calcium level. So although chronic kidney disease and vitamin D deficiency produce different phosphate levels, they both share the same underlying mechanism. Low calcium stimulates increased PTH secretion. That's why both conditions are classified as secondary hyperparathyroidism. Now let's move on to what is often considered the trickiest form of the three, tertiary hyperparathyroidism. Fortunately, if you've understood anything we've discussed so far, tertiary hyperparathyroidism makes perfect sense. Think back to chronic kidney disease. Patients often spend years with persistent low calcium and chronically elevated PTH. What do you think happens if the parathyroid glands are continuously stimulated for years? Eventually, the glands undergo hyperplasia. Over time, they become autonomous. Instead of simply responding to low calcium, they begin producing enormous amounts of PTH on their own. PTH levels may reach several hundred or several thousand. At this point, the disease has transitioned from secondary to tertiary hyperparathyroidism. Here's a classic board-style scenario. A patient with end-stage renal disease undergoes a successful kidney transplant. Several months later, laboratory testing shows persistently elevated PTH and now elevated calcium. What's the diagnosis? Tertiary hyperparathyroidism. Even though kidney function has improved, the hyperplastic parathyroid glands have become autonomous and continue secreting excessive amounts of PTH. Take a deep breath. This is one of the most challenging endocrine topics, and you're doing great. Remember, don't focus on memorizing isolated laboratory values. Instead, ask yourself, why is the calcium changing? Why is the phosphate changing? And why is the PTH changing? If you can answer those three questions, you've mastered the physiology. Now let's see if we can put everything together with two rapid-fire practice questions. Question 1. A 65-year-old woman presents for a routine follow-up. Her medical history is notable for recurrent kidney stones. During the physical examination, you palpate a nodule in her neck. Imaging and biopsy confirm a parathyroid adenoma. Before I give you the answer, pause for a moment. Can you predict her calcium, phosphate, and PTH levels? This is primary hyperparathyroidism. You should predict elevated PTH, elevated calcium, decreased phosphate. Excellent. And don't let the kidney stones distract you. In fact, they support the diagnosis. Persistently elevated calcium increases urinary calcium excretion, which can lead to calcium-containing stones. Question 2. A 60-year-old man with chronic kidney disease presents with gradually worsening bone pain over several years. Before I explain the answer, pause and predict his laboratory values. This is secondary hyperparathyroidism caused by chronic kidney disease. You should predict elevated PTH, elevated phosphate, calcium that is often low, but sometimes low normal. That last point is worth emphasizing. Many board questions intentionally report a calcium level within the normal range. Why? Because prolonged elevations in PTH increase bone resorption, partially compensating for the kidney's inability to maintain calcium balance. So don't become anchored on a normal calcium level. Instead, identify the underlying disease process responsible for the elevated PTH. That's the key to answering these questions correctly. Before we finish, I'd like to briefly mention two important exceptions that are worth recognizing. Certain malignancies, including squamous cell carcinoma of the lung and renal cell carcinoma, may produce parathyroid hormone-related peptide, or PTHrP. PTHrP mimics many of the actions of PTH, causing hypercalcemia despite a suppressed endogenous PTH level. Another important exception is sarcoidosis and other granulomatous diseases. Activated macrophages within granulomas express 1-alpha hydroxylase, leading to excess production of active vitamin D. This increases intestinal calcium absorption and can also produce hypercalcemia. Notice that both of these conditions result in elevated calcium with a suppressed PTH, helping distinguish them from true hyperparathyroidisms. These are less common than the disorders we discussed today, but they're classic board-style exceptions and are worth keeping in the back of your mind. In general, as you may suspect, treatment and management will focus on the underlying etiology and can vary. I'd like to leave you with one final way to think about hyperparathyroidism. When you see an elevated PTH level, whether on an exam question or in a real patient, ask yourself one simple question. Why is the PTH elevated? Is the parathyroid gland itself producing too much hormone? That's primary hyperparathyroidism. The gland is the problem. Think high PTH, high calcium, low phosphate. Or is the parathyroid gland simply responding appropriately to low calcium caused by another disease? That's secondary hyperparathyroidism. The gland is doing exactly what it's supposed to do. Think chronic kidney disease or vitamin D deficiency. Or has the gland been stimulated for so many years that it has become enlarged and now secretes PTH autonomously? That's tertiary hyperparathyroidism. It began as a secondary disease, but eventually the gland stopped listening to normal feedback. If you can answer that single question, why is the PTH elevated, then the calcium, phosphate, and vitamin D levels often become much easier to predict. Don't memorize the laboratory values. Understand the physiology, and the laboratory values will follow. Thank you for listening. If you found this episode helpful, please subscribe to our podcast. If you have any questions, comments, concerns, visit our website at spoonfulofsugar.org and post them under the link for this episode. Good luck with studying, and remember that if you ever have an SOS moment while studying, Spoonful of Sugar is always here to help the medicine go down.